Dear conference delegates, distinguished guests, friends, colleagues, ladies and gentlemen, allow me to welcome you warmly in the first plenary of the Union Conference 2020. This year, this conference is unique. We have all been greatly troubled by a new public health threat that has turned our world upside down. We would have loved to meet Great Charter Network as usual. However, COVID-19 has made that impossible. While global attention has been focused on COVID-19, we need to remember that all the enemies have not gone away. One of our oldest enemies, of course, is TB, a disease that many of you in this room have committed your lives to fight. We know we haven't made the kind of progress we need to make. The WHO has just released its annual report that again tells us that about 10 million people developed TB in 2019, and 1.4 million people died of the disease. The question, therefore, is there hope? Will humanity ever conquer this disease? Today, in this plenary session, we will hear from eminent speakers that indeed there is hope. That hope lies in prevention of TB. We will hear where we are with vaccine development, how we can scale up TB preventive therapy, and how we can empower people to push for elimination of TB stigma, discrimination, and to ensure the right investments are made to deploy existing tools to those who need them. Ladies and gentlemen, allow me to introduce you to the first speaker in this plenary session, Professor Helen McShane, who is currently Director of the Oxford NIHR Biomedical Research Center, Professor of Vaccinology at Oxford University, and Deputy Head and Honorary Consultant Physician in Infectious Diseases. Helen, you have the floor.
Hello, I'm Helen McShane, and I'm Professor of Vaccinology at the University of Oxford, and I lead the TB vaccine programme here at Oxford. And I'm delighted with this invitation to talk to you today about TB vaccines. I have no conflicts of interest. And really what I'm going to focus on is both the very old and the very new in this presentation. The very old, BCG, and the very new, the most recent advances in the field of TB vaccine research and development. So firstly, to talk a little bit about BCG, a vaccine that you will all be very familiar with. BCG really started to be developed at around the time of Jenner. We had Jenner developing a vaccine against smallpox, indeed the most successful vaccine, the only one that has led to eradication of disease, and the observation that cowpox protected against smallpox. And if you like, there's a similar parallel here where we have Mycobacterium bovis protecting against Mycobacterium tuberculosis. And of course, BCG is live attenuated Mycobacterium bovis. The first early trials of Mycobacterium bovis were taking place in Italy. And in 1908, we had two French scientists, Camille and Guérin, who over many years passaged serial passages of Mycobacterium bovis, attenuating it, making it less virulent, and allowing us to use this as a safe and effective vaccine. They proved the attenuation by determining that BCG, as it is now known, was not pathogenic, did not cause disease in animal models. So BCG was first used routinely in humans in 1921, and I'm looking forward next year to being able to say BCG has been around for 100 years, because I've spent the last 10 years saying BCG has been around for almost 100 years. The acceptance by the public was slow, and indeed there's no change in that today, with concerns about the anti-vaccine lobby rife throughout the world. There were some early hiccups. So we had the Lübeck disaster, where instead of being given live attenuated BCG, some infants were unfortunately given virulent tuberculosis instead, and many of those infants died. BCG remains the only currently available and licensed vaccine against tuberculosis, 99 years after it was first developed. So where are we with the efficacy of BCG? Well, you will know that there have been many studies looking at how effective BCG is that have taken place throughout the world and over the last 50 years. And what we know when you put all of those studies together is that BCG is very effective at conferring protection against disseminated disease. This is TB that is spread outside of the lungs, particularly in childhood, particularly against TB meningitis. It's also effective against protecting against leprosy caused by Mycobacterium leprae. We know that there are many countries, and I'll show you a summary of this data in the next slide, where BCG is effective at protecting against pulmonary disease. And there's also some evidence from some studies that BCG may confer what we consider non-specific protective effect. So this means protection against things like all-cause mortality, particularly in infants. These studies are somewhat controversial. And it's a field where we urgently need more data and more evidence on this. I think it is irrefutable that BCG confers non-specific protection against bladder cancer. So we do have some definite evidence of a non-specific effect. So if it were that easy, of course, then we wouldn't be desperately trying to find a new vaccine. And the challenge here is the variable efficacy that BCG confers against pulmonary TB. I've said that there are many countries where BCG does confer good protection, but there are even more, and they are the countries where TB is most a burden of disease, where it doesn't protect sufficiently. And it's also contraindicated in immunocompromised people. So I hope you can see this cartoon taken from a paper from Paul Fine. And you can see this slide lines up, I hope you can see my pointer, the different studies that have been done looking at the efficacy of BCG, and then looking at whether those studies showed a protective effect or not. Anything with a line to the left of this vertical line shows protection. Anything where the horizontal line spans that vertical line means there is no significant effect. You can see at the top of the slide studies like the British MRC study conducted in the UK, demonstrating a high level of efficacy durable for 20 years. But if you go down to the bottom, you can see studies like Chingleput in South India, where there was no demonstrable efficacy at all overall in that study. And it is this variable efficacy that is the problem with BCG. What we need is a vaccine that is less variable and more universally protective. So how do we go about developing a better vaccine? How do we start thinking about this? Well, really, the focus needs to be to thinking about who do we most need to develop that vaccine for, because depending on the target population, that will alter the way we develop a vaccine. And there are three main target populations for a new TB vaccine. Infants, particularly in low and middle income settings, have a huge burden of disease, particularly in sub-Saharan Africa. We know that adolescents and young adults have a high burden of disease, not quite as high as infants, particularly in Southern Africa, but a very high burden of disease. And of course, this is the population where the biggest impact economically falls with TB. So this is a particularly important population to target. And we also know that adolescents and young adults are the population responsible for transmission. Infants do not develop SNP-positive disease and do not transmit TB. So if one wants to have an impact on transmission, then one needs to vaccinate adolescents and young adults. And HIV-infected adults remain at increased risk of tuberculosis, despite highly effective antiretroviral therapy. So they remain an important third target population. The other way to look at this, other than a sort of conventional, what are the risk groups for developing a new TB vaccine and what is the target population, is thinking about what the indications are from a mycobacterial perspective. So if one is to stratify by mycobacterial exposure, then one has three different categories of populations that people could use a new TB vaccine in. First, prophylactically, and this is really talking about either infants or it's talking about TB uninfected adolescents and young adults. And this is the most conventional way to use a vaccine, is prophylactically and give it to people before they have come into contact with the pathogen. There's another indication in TB, which would be to give what we call a post-exposure vaccine. This would be to give a vaccine to people where they are already infected, latently infected with TB, in order to prevent the reactivation of that latent infection and prevent them developing disease, and perhaps to eradicate latent infection. And then finally, a therapeutic vaccine may also be of use, particularly in drug-resistant situations, where we could give a vaccine not instead of, but as well as chemotherapy, as an adjunct to chemotherapy. And there is a lot of work focusing on this and focusing on developing models where we can test this kind of indication now. So that's all well and good. We have some theories as to, and some ideas for who we would like to give a new TB vaccine to. Well, what I'm showing you now is the clinical development pipeline in 2000. And it's deliberately a blank slide. There were no new TB vaccines in clinical trials in the year 2000. And I think what this illustrates, along with the drug development field and with the diagnostics field, is the decades of neglect in this field that we are really playing catch up for. I'm very happy to show you in 2020, 20 years later, we now have a vigorous pipeline of vaccine candidates at different phases of clinical testing, different kinds of vaccines, different technologies being tested. This is fantastic, but clearly it's really important we keep this pipeline going and continue to develop new candidate vaccines for testing in the clinic. So just a few slides now, giving you some examples of the approaches being used and the information we can gain from these clinical trials. So firstly, a slide here on the first efficacy trial in infants with a new TB vaccine, MVA85A. This was work we led in Oxford in very close collaboration with colleagues and collaborators in South Africa, in the United States, and indeed in many other countries and organizations around the world. We did not see any signal of efficacy in this trial in nearly 3,000 BCG vaccinated babies, which was an enormous disappointment. But one of the things we did do was take the immune correlate samples taken from infants in that clinical trial and interrogated those to try and understand immune correlates of risk and what we could do to use that information to develop better vaccines. And one of the interesting things we found was that concurrent CMV infection, as measured by T-cell responses to CMV-specific antigens, was associated with an increased risk of developing TB disease, and that the infants that were CMV positive developed their TB disease earlier than the infants who were CMV negative. There's clearly an enormous amount of work that needs to be done with this, but I think it does give us a sense that the infectious milieu in which a baby or an adolescent or adult in a TB endemic country lives may impact the efficacy of vaccines and the susceptibility to TB, and we need to do more work on this. Following on from the results of that infant trial, there was a lot of thinking in the field as to how we could do better, how we could learn from that trial, and there were two main changes. One was to focus on adolescents and adults rather than infants because of that risk of transmission, and because there was an observation that some candidate vaccines were less immunogenic in children and in infants. There was also a shift of focus from prevention of disease trials to prevention of infection trials, because a prevention of infection trials give you a much faster endpoint, because the incidence of infection in most populations is much higher than the incidence of disease. The one caveat to this is, will a vaccine that prevents disease necessarily prevent infection? And we don't know the answer to that, and only further clinical studies can help us determine that. But I think this is a useful approach to develop a model where we have a biological signal in humans that gives us the confidence to carry on with larger prevention of disease efficacy trials. I'm now going to show you the results of two other efficacy trials, the only two other efficacy trials that have been reported. And the first here is using two strategies. One is a protein adjuvant, hybrid 4, IC31, and the second is to use BCG revaccination. This is in TB and HIV uninfected adolescents. And the results of this study, the primary endpoint here was quantiferon conversion, and the secondary endpoint was sustained quantiferon conversion, showed that although no vaccine candidate met the primary endpoint, the BCG revaccination met the secondary endpoint of sustained quantiferon conversion. And there was a 45% reduction in sustained quantiferon conversion, significant result with BCG revaccination. This is a fantastic result, gives us a biological signal of efficacy. There's a lot more work that needs to be done interrogating this, but it really helps demonstrate that this is possible. It's proof of concept that it is possible to do better than BCG alone. The other study, which again is an enormously important result, is the result of a protein adjuvant vaccine, M72 AS01E, being developed by GSK. And this vaccine was used in an efficacy trial prevention of disease study in adults who were already infected. So this is a prevention of disease, if you like, in a post-exposure setting. And highly significant result, 50% vaccine efficacy over 3 years of follow-up. Again, enormously important result. Clearly more questions. Does it work in people who are not latently infected? We don't know the answer to that yet, and only more work will give us these answers. But I think after decades of neglect and after that empty pipeline 20 years ago, we've come an enormously long way, and what is critical as we continue this momentum now. Thinking through about deployment, it's all very well developing vaccines, but we must think about how we're actually going to use them. I think for the booster vaccines, and the examples I've given you are of booster vaccines, clearly they could be used in infancy to reduce that high burden of disease. They could be used in adolescence, which is slightly harder because we don't have many routine vaccination programs in adolescence. But clearly with HPV programs, these vaccines can be linked into school programs. And one key question is, would we vaccinate everyone or only those who are quantiferon positive? And I think from a logistics point of view, we'd want to vaccinate everyone, and we may well need catch-up campaigns. BCG replacements are a different way of thinking about vaccines. And I think one of the important things here is to be sure that they are non-inferior in all regards, including potentially in the non-specific effects. I'm going to show you now 2 slides of other candidates, both of them in fact BCG replacement vaccines that are currently being evaluated or just will soon be evaluated in efficacy trials. The first is VPM 1002. This is a recombinant BCG developed originally by Stefan Kaufmann. Here you have some animal data showing recombinant BCG is more protective. And these are the results of the first or one of the early clinical trials showing the immunogenicity of this vaccine. It's now being tested in several efficacy trials throughout the world. And then next we have MTBVAC, which is a rationally attenuated strain of TB developed by Carlos Martin at the University of Zaragoza. Here is some non-human primate data showing it is more protective than BCG. And here is the result of the first-in-man human study testing the safety and immunogenicity of that vaccine. I'd like to finish by showing you 3 slides of some more experimental work. The first 2 slides are in non-human primates. This is a non-human primate model showing that intravenous BCG is significantly more protective than intradermal or aerosol BCG. Now, I don't think that intravenous BCG is a deployable route of vaccination, but I think this is a really important study that can help us determine the mechanisms of this enhanced protection, and we can then develop deployable vaccines that induce this mechanism of protection. We also see that a vaccine that is a CMV vector TB vaccine, so this is a CMV virus delivering TB antigens, is significantly more protective in a non-human primate, significantly protective in a non-human primate model. This is work really that has paralleled the work of this vector in the HIV vaccine field as well. Lots of questions, which I don't have time to go into today, but we'll be delighted to discuss in the question and answer session about any of these strategies. And then the final approach is one we're exploring here in Oxford in my laboratory, which is delivering a vaccine direct into the lungs. We know that TB enters the body via the lungs, and it makes sense in many ways to deliver a vaccine to the lungs and develop immunity at the point of entry of the pathogen. There are many drugs that we already routinely deliver to the lungs, and we've been doing some early experimental medicine studies demonstrating the safety and the potency in terms of immunogenicity of this route of immunization. So I hope that that has given you just a flavour of the excitement in this field after the decades of neglect. There really has been huge progress in this field in the last 20 years, and it is critical that we continue this momentum. I hope I've demonstrated that we can learn a lot from well-designed efficacy trials, regardless of that efficacy outcome. And we must understand these efficacy trials must store correlate samples so we can interrogate them as much as possible. We need better tools for vaccine selection. We need validated animal models and immune correlates, which will transform this field. But at the moment, there is no substitute for human efficacy testing in the quest to develop an ETB vaccine. Thank you.
Thank you. Hello, my name is Rovina Ruslami. I'm from Universitas Padjadjaran, Bandung, Indonesia. In the next 15 minutes or so, I would like to talk about the lesson from the TPT implementation. I have to declare that I have no conflict of interest, and this is the outline of my speech. We all know that a quarter of the world's population are estimated to have latent TB infection, and in 5 to 10% of them will develop active TB disease. So definitely latent TB is the fuel for TB disease, and if we don't treat them, it will be a disaster. Therefore, the TPT is a key component of anti-TB strategy. In September 2018, the UN high-level meeting on TB already set the target to reach at least 30 million of people who need TPT by the year of 2022, and the population at risk to be targeted is the children under 5, people living with HIV, and also the household contact. Even though the implementation of the TPT is already started from 60 years ago, and evidence shows that it is effective, but until now, the implementation of TPT is still far from the optimum. Data from 2018 show us that the coverage of TPT is less than 20%. It is only 27% of children under 5 started the TPT, and even only 2% of household contacts started the TPT. Since the individual who will receive TPT is relatively healthy and the number to be treated is huge, so safety and adherence or completion of the treatment is two things to be considered. The ideal regimen for TPT should be short, safe, efficacious, easy to take, and also inexpensive. There are two groups of treatment regimen available now. The first one is the INH monotherapy, where the patient should take the INH for 6 to 9 months daily. Actually, this regimen is okay in terms of efficacy, but the duration of treatment and safety profile, which is hepatotoxicity, make the INH monotherapy regimen has drawback. And the second one is the rifamycin-based shorter treatment. So to tackle the condition, the situation with the INH monotherapy, in the past 2 decades, multiple randomized trials have identified the suitable LTBI treatment regimen using rifamycin, either this is rifampicin or rifampicin. And these two tables shows us the comparison of efficacy and safety of shorter TPT regimens. In terms of efficacy, there is no doubt that this shortened regimen have the similar efficacies. But with the safety profile, the rifamycin-based regimen show a better profile in terms of hepatotoxicity, either this is the 3 HP or 4 RIF or 1 HP. So based on that, WHO GDGs already recommend that nowadays the treatment option for TPT are multiple, that we can use which one is suitable for our patient, whether we would like to use the INH monotherapy or we will use the rifamycin combination with INH. And National TB program also very much advised by WHO to choose the shorter rifamycin-based regimen because of the better safety profile and better prospect for completions. As other countries, Indonesia also follow the WHO guideline to give IPT to under 5 years old children that have contact with the TB patients. And our study in 2013 tried to follow this target population, and we show that there is a huge policy practice gap. Of 437 of children has contact with TB, only 34 of patients of them who start the screening for beginning the IPT. And for those who doesn't come to the clinic, we are able to contact another 130 children, and only 39 of them eventually start for the screening for the IPT. So this study showed us that the vast majority of children have contact with TB patients don't even have screening at the first place. And with the health needs assessment approach, we try to break down the system into parameters, and then in each parameters, we set the target performance, and then we try to compare with what we observe in the field. So definitely in each step, we can see that in each step, there are huge gaps. For example, in this slide, the gap is about 82%. One systematic review is conducted by the team in 2016 shows using the Cascade of Care. I would like to explain a little bit about Cascade of Care. So actually there are steps in patient trajectories before the therapy is begun. And there are losses and dropouts in each stage of Cascade of Care of LTBI globally, not only in Bandung. So in the systematic review and meta-analysis I mentioned before, we can see here there are a lot of gaps in every step, and only 30% of the patients should receive the TPT, they start with the treatment and end up with only 19% of them completed the treatment. There are several barriers or problems happen in the field. For example, patients' knowledge and behavior, healthcare provider perspective about the TPT, and mainly the health system. So if we want to achieve our target, we should address this gap in every step, and we should do something. We should do intervention. To respond to this call, a cluster randomized trial was conducted in 2016-2019 in 5 countries, in Canada and 2 countries in Africa, and also 2 countries in Asia, to represent the high-income countries and low-middle-income countries. The study is conducted to test if a package of standardized public health evaluation and need assessment, followed by target solution, will enhance the number of health contact to start the TPT. So this is the design. So 24 healthcare facilities are randomized to receive either intervention or just continue with what has going on in the field. Intervention have 3 phases: evaluation phase, feedback session, and strengthening phase. In evaluation phase, we do problem identification by asking and looking for the data, how many are losses in what step, and then about also what is the reason for the gaps by performing collecting the qualitative information. After that, we sit together, discuss it with the stakeholder about the findings, and try to find the best solution and which is feasible for our side. And then we implement our chosen intervention in the field and look at the result. So the intervention is site-specific. For example, in Indonesia, we choose 4 intervention, which is in-service training to the healthcare worker. We train them how to fill in the registry, how not to forget to contact the target. We also develop a flip chart. With this flip chart, can be used by healthcare worker to approach the target, the patient, as well as the household contact. We also develop the reminder system that link to the registry to also lessen the burden of our workers in the field. And the last one is something small, it's cheap, but attractive for the kids. We provide the kid toys. The price is only about $1 or $2 US. This table shows us the main result of the study. Intervention do give an impact about the number of target who initiated the TPT, and the result is even shown in the low and middle income countries. So what we can learn from this trial is that the intervention is really work in low middle income countries and was relatively cost effective. And this approach provides a logical framework for implementation that relies on local data, and we can also mobilize the key stakeholder to choose the intervention. Training is really a long-term investment, and understanding motivators for healthcare workers is really essential if you want to success. So apart from the cascade approach that has been discussed before, advocacy is also essential to put PMTPT as a priority apart from. In the next slide, I would like to share the situation in Indonesia. Indonesia, the NTP of Indonesia also set the target for TPT. By the year of 2024, we aim for achieve 1.3 million of household contact, including those targets. But in the reality, our achievement is far from satisfaction yet, because our achievement is less than 10%, and it is also augmented by the current situation of pandemic COVID-19. In the May this year, our NTP do a survey into the more than 400,000 respondents in 30 provinces in Indonesia, we do find that there are a lot of challenges faced by not only the program manager, but also by the primary healthcare, including the cadres who usually already help us in the field. And in the last August, we managed to do the first virtual conference about TB and COVID-19. The conference was pretty successful because we can bring along all stakeholders, including the healthcare workers, TB program managers, the government, as well as the academia, to raise the awareness that our homework, tuberculosis, shouldn't be forgotten. Our special event called Voices from the Field, where we invite the field from the warriors from the field to share their current situation, what they are facing, and what challenge they have, and then what innovation they already made so far, shows us that the spirit is still there. We want to continue to have a regular virtual meeting to help them, to be with them. How can we together solve the problem? So the summary, the TPT implementation is currently suboptimal and impacted more by the COVID-19. A massive expansion of TPT services is much needed by redesigning the PMTPT, by strengthening the health system using systematic approach, choose the locally feasible solution, and involve the community. Mobilization of resources is a must, it's nothing we can do. And the last, advocacy, commitment from the government and stakeholder is really essential. Last slide, I would like to say thanks to all my colleagues and collaborators from McGill University, Montreal, Canada, led by Prof. Dick Menzies, and also from the Otago University, led by Prof. Philip Hill, and also all Act 4 research team, and also to the Municipal Health Office, TB HIV Research Center, NTP, and also the last is my all college and researchers in Indonesia who already work in TPT. Ladies and gentlemen, thank you for your attention.
It will forever remain an accusation and a challenge to all men and women of conscience that it took as long as it has before all of us stood up to say enough is enough.
South Africa's first president had TB. This came as a surprise to me because I thought I was TB proof. I also thought I was not racist. I was wrong.
And today I become a statistic myself. 6 weeks and 1 day later, I'm meant to become a much maligned TB defaulter. Can't continue this for another 5 months without even knowing whether the treatment will work. And that's the bottom line. We need better diagnostics. And we sure as hell need better treatment for latent and active drug-resistant TB.
I've been living with multi-drug resistant TB infection for a decade now. I expected people to care, but they didn't. This came as a shock to me, not because of the TB infection. I mean, who cares about TB infection? I expected them to care about me. So I complained about it, loudly and bitterly and constantly. I co-founded an advocacy organization, I traveled the world, and I ended up at the United Nations, where the world's experts listened to me.
The last refinement to that statement, we must test and treat all types of TB infection, including drug-resistant infection. Great, I'm prompting you a bit, but this is very encouraging. With your clapping, you all agreed that today we are going to test and treat everyone.
On that very same day, the world promised to put 4 million people like me on TB preventive therapy. Even Anthony Fauci was there. In year 1, we managed less than 80,000. That's 2%. An obvious problem was the World Health Organization's double standard. Their 2018 TPT guidelines recommended test and treat for people like me if you lived in a rich country. If you lived in a poor country, euphemistically called a high TB burden country, testing was not required. This was clearly not what we had agreed to, so the world's experts had another think. This year they concluded that people like me living in rich countries, lives mattered just as little as those living in poor countries. Test and treat was scrapped altogether. TPT was left sort of optional. Do our lives really matter so little to you? Apologies, that's not fair. My life matters, of course it does. But TB is not my problem because I'm TB proof. I'm infected, yes, but I can't become ill, just as I was taught in second year medical school. But that is not what I mean when I say I'm TB proof, and that is not what the doctors in my teaching hospital meant. Because we were racist, and we were wrong. You see, being immune has two meanings. The first deals with white blood cells and antibodies. The second is political. Immune means to be protected or exempt, especially from an obligation or the effects of something. What the experts teaching me meant, and what I believed, is that we were better than the people we were caring for. My privilege protected me, my education, my skin color. White privilege meant that people like me were exempt from getting TB. And because people like me couldn't get TB, people like me didn't care about TB. Being TB proof doesn't refer to immunity or white cells. It refers to whiteness. I grew up in a post-apartheid, democratically free South Africa with all the benefits of extreme white privilege, but none of the guilt. At the elite, all-male Afrikaans high school, we were repeatedly told that we were better than everyone else. It was all too easy to believe, especially for the school's top achiever. In medical school, things were even worse. On day one, the dean told us that we were the cream of the crop, and I was the creamiest of them all. Yet, despite working in the same hospital where I was born, I really struggled to relate to my patients. We lived differently, we spoke differently, we looked different, and we had very different problems.
2 weeks ago, I won't give the lady's name, she lives about a few huts down. Her child was very ill, 1-year-old baby. There is no clinic nearby, and so they walked to the big river, they took a ferry across, they went by, waited for the taxi, went up. By the time they got to the doctor, they went to Elliotdale, the doctor wasn't there, they went to the next doctor, he wasn't there, and the baby died. And we had a funeral here last week, and that was obviously a very sad occasion for the whole village.
We became less different in my second year as doctor. My cousin and roommate spent a week in a private hospital before he was diagnosed with occupational pleural TB. The private pulmonologist treating him refused to believe that he could have TB any sooner. You see, Bart was like me, healthy, athletic, bright, white. People like Bart couldn't get TB, and if they somehow did, it was no big deal.
I was going to see how far I can swim. I came up grasping for air. I was ecstatic. I knew I had broken the South African record, and I knew that I had proven that after TB I could really function at a great capacity.
If anything, I now cared even less about TB. Bart was an exception, and his recovery exceptional. More proof of how different we were to those we cared for. 2 years later, everything changed again.
We thought it was just a dry cough, just sinusitis. We didn't realize that it was MDR TB. I didn't have any other symptoms. I was at home, I was waiting for the sensitivity results, and Arne was at work.
I was at work when the pulmonologist phoned me, and the first thing he told me is, I'm sorry, things are looking bad.
2 months later, things got even worse. I mean, when Helene was starting to lose her hearing, the first doctor said, well, it's deaf or dead. And we thought, oh, that can't be right. And a colleague who will remain nameless said, I hear what you're saying, but until you're ready to put a bullet through your brain, we're not going to stop the drug. Those were the words. But deaf or dead is not a fair choice. And it's a treatment that causes it, not the disease. In that same Valentine's week, I also became sick. I took a short diary of that horrible week in February. Yeah, this is going to be difficult. I wrote down a quote on that morning, 20 February. When I got up, music was playing in the house, full blast. And Helene said, I'm sorry. I'm sorry, but I'm so sad this morning. Why must I lose my hearing? Haven't I suffered enough already? And then something astonishing happened. We stopped mattering. Our employers didn't care. Our colleagues didn't care. The world didn't care. Deaf or dead or both. This is why. Stigma. Stigma is defined as a mark of disgrace associated with a particular circumstance, quality, or person. TB was that mark on my family, on those I love. How dare you disgrace my uncle, my cousin, my brother, my wife? How dare your treatment be worse than the disease? Deaf or dead? How dare you? Yes, you, not TB. You, the TB expert, the one with all the power. Yes, I'm speaking to you because I remind you of you, and you remind me of me. That is why Helene was the first person to get access to Biomedical, fully 7 years before it became policy for everyone else. We told the world she was lucky. Lucky, yes, because she was a white doctor working with the best white TB experts in the world, who were friends with the best white TB drug developers in the world. Lucky that cost was not a factor and support was never in doubt. But what about everyone else? Everyone that breathed the same air as Helene. Her employers didn't screen her patients, her colleagues, or her family members. I was not screened after 6 weeks of intense exposure, and when I became ill after 2 months, I wasn't treated. When I eventually attempted TB preventive therapy, I quit after 6 weeks, literally crippled by a drug with 4 black box warnings on it. You're going to take the stairs or the lift? I think the stairs are safer, right?
Yes.
I've lost count of the amount of x-rays I've had and the amount of sputum samples I've sent, because the problem is every time I cough, that could be the first cough of my TB reactivation. That's right, yes. I've got long lines there. It's a challenge to get it all out. Look at that, eh? Sakari spotted something on the x-ray, and she also then looked at the previous report and it was different.
This could be secondary TB.
If there is something brewing, then you never know when it pops up. And I've got 2 small children under 5.
This time, Arne was lucky. Although his x-ray was unusual, follow-up tests confirmed it was a false alarm.
TB is terrorizing me because it's a fear that is currently the bigger problem rather than the disease. You see, TB is not done with me. It has left its mark on me. The dark stain of fear, of stigma, of blackness. Did the doctor just call TB racist? No, I didn't. I called us racist for treating people differently. TB used to kill everyone. Now it mainly kills poor people, oppressed people. marginalized people. You know the type, black and brown people. In 2018, TB killed 1.5 million people. 90% of deaths happen in countries where the majority of people are not white. Even in so-called white countries, TB disproportionately affects people that are not white because of structural violence and systemic racism. And that is exactly why TB is so stigmatized. If you get TB, you are all those bad things. You become less. You are worth less. You matter less. This is the truth about being TB-proof. If you get TB, you stop mattering. Because people in positions of privilege want to believe they are immune in every way. This is why our first vaccine was our last, despite being lousy. This is why our TPT options haven't changed in 63 years, despite having newer and safer drugs available, and why the World Health Organization's guidelines are so out of touch. But is it racist?
All racism is inherently a challenge to human rights because it denies the view that every human being is a person of equal worth with any other, because it treats entire peoples as subhuman.
Sound familiar? Dot, deafness, defaulter, suspect. These are terms and policies we wouldn't dream of using for ourselves or our loved ones. And that strikes at the heart of the problem, doesn't it? Those with TB are not our loved ones. Like all of you, I had the best intentions to help people, but these were framed in my whiteness. If you were different, different rules could apply. This might have been acceptable if different didn't always mean less. I only started understanding this when my loved ones became ill. Suddenly what was good enough for millions was not nearly good enough anymore. To fight this, I needed help. I got it from the people that had always gotten less, including from me. For this, I'm deeply sorry, and I salute and thank you. Structural violence, systemic racism, white privilege. Discrimination has many names, but one purpose, and TB feasts on it. I call on you to actively attack every thought and system that punishes people for being different. Only then will your excellent intentions translate into excellent care for everybody. I thank you.
The world is currently experiencing a major health crisis, the COVID-19 pandemic, and there have been signals that BCG vaccination may have helped some regions to escape the worst of this pandemic. This is topical, and I'm wondering what your thoughts are. We know that a major driver of TB is poverty and associated social determinants. Could I therefore be a little provocative and ask the question, shouldn't we just be spending our resources to tackle those social determinants of TB instead of chasing a vaccine that has been so elusive for so long? And finally, as the science to find an efficacious vaccine progresses, should we also be thinking about potential barriers to deployment of new vaccines when they become available, and how we should overcome those barriers?
Thank you. There are three very good questions there, and I'll try and answer each of them briefly. In answer to your first question, the suggestion that BCG, our only licensed vaccine against tuberculosis, may be protecting against COVID. We don't have any robust data to support this at the moment. There are some epidemiological studies and some retrospective studies which show differences in COVID rates, which are stratified in countries by BCG vaccination rates. However, those studies are subject to many confounders. There are randomized controlled trials ongoing in healthcare workers in the Netherlands and in Australia that will answer this question definitively, and we need to wait for this data before we make a judgment on this effect or not. It's really important that supplies of BCG around the world are not diverted for COVID and diverted from the people who need it most to prevent tuberculosis. In answer to your second question, of course, TB is a disease of poverty, but I don't see this as an either-or scenario. We know that any improvements cannot stop people getting TB, and there has been enormous progress in the quest or the search for a new vaccine in the last 2 years. We now have 2 vaccines, both BCG revaccination preventing infection and M72AS01 preventing disease in people who are already latently infected. More work is needed, but I think after decades of neglect, we now have 2 very promising strategies that need further work. But I don't think the ultimate goal of a more effective TB vaccine is as elusive as it was once seen to be. And finally, your comment about barriers to implementation, of course you're right, and of course we need to, in parallel with developing vaccines, work with communities, work with countries where TB is most endemic to try and understand how we can best deploy these vaccines so that when we have the vaccines ready, we also have communities ready to use those vaccines. Thank you.
Thank you, Helen. And now allow me to introduce our second speaker in this plenary, Professor Rovina Ruslami. Professor Rovina is head of Department of Biomedical Sciences at the Faculty of Medicine, University of Padjadjaran, Bandung in Indonesia. Professor Rovina will talk to us about scaling up of TB preventive therapy around the world. Thank you, Rovina, for a great presentation. You have shown that TB preventive therapy can be delivered at the programmatic level. Unfortunately, the pace of implementation still remains low. And I'm wondering what your thoughts are about the major barriers to scaling up TB preventive therapy from both the system side and from the people side, and how those barriers may be overcome, especially in relation to treatment of essentially well people. Do you think that if we were to scale up treatment of TB preventive therapy in well people, in addition to doing other things, we could bring down the incidence of TB?
Thank you very much, Mr. Chakaya. Yeah, it's true that despite the importance of TPT and a lot of evidence about the success, effectiveness of the treatment, but so far the implementation is still low. Unfortunately, this situation is not simple about why it's happened, as the success of the program is really depend on the system and the people side. I think the major barrier from the system side is to really put it into the system itself, how the NTP should really calculate the target and then calculate also the cost, and then to make the policy and break down it into the practical guidelines that can be used in the field. And of course, not to forget to invite all of the stakeholders to also take an action and take their part. As from the people side, the major barrier, I think there are 2. First is that the knowledge gap. The knowledge gap will lead to the behavior, acceptance, and willingness to be in the TPT program and to complete the TPT. And second one is the fact that we will treat them sort of well and healthy people. It is difficult to make them understand to start and to continue and to complete the treatment. And the second one is about the safety issue. But luckily, the more evidence now that we should also move into the shorter regimen based on the rifamycin-based regimen that are proven to be safer and well tolerated by the subject, and also give a promise that probably the completeness will be better. And second one, if you ask me, do you believe that it should be done? Yes, I do believe. Even though the TPT is not easy and also not inexpensive, but think about the consequence if we don't do it. It will be, I think it will be more difficult and more cost will be paid, and no one would like it to be happen in the future. So yes, we should stick to TPT. We should really put our effort to succeed the TPT into the programmatic. Thank you.
Thank you very much, Rovina. And now allow me, ladies and gentlemen, to introduce to you Dr. Ann Von Deft. who grew up wanting to help people and was given every possible opportunity to do so in post-apartheid South Africa. He will share his privilege, why his privilege did not protect him or his loved one once again as the leading cause of death in South Africa, and why his good intentions were not enough to protect those he cared for against structure of violence, inequality, and systemic racism. Please join him as he reflects on 3 decades of hope, prejudice, triumph, despair, and love. Thank you, Anne, for the very moving testimony. If I may ask, could I ask you from the perspective of people who have walked the TB journey, where do you think the science for the prevention of this horrible disease should go? What are the top priorities? The second question I would like to ask you is the stigma, the discrimination, the negativity that is associated with TB just doesn't seem to go away. Tuberculosis is almost often seen by many as a disease of others, and somehow people of lesser importance. Is this contributing to low investments in research and development, and what could be done to address this issue? In your view, what are the practical 3 things that should be done by governments, the World Health Organization, the Stop TB Partnership, the Union, and all of us to end stigma once and for all?
Thank you, Chakaya. I think you hit the nail on the head. Why do we manage people with TB differently? My only conclusion is that their lives matter less. Let's look at our COVID response. Our TB vaccine is 100 years old, but for COVID, we have nearly 200 candidates within the space of 1 year. Infection prevention and control is finally taken seriously. Even worse indictment is the fact that we almost completely dropped TB service while we were responding to COVID, even though the diseases transmit and present in the same way. This was a massive missed opportunity. Why is there no urgency from the experts either? Why does it take so long to adopt new tools, new diagnostics, injectable-free regimen? My only conclusion is that people with TB matter less. We also know that Black lives matter less. What is the conclusion here? Are we as a TB response not racist? Yes, I know we have good intentions, but those don't always translate into good outcomes unless we truly believe people are equal. So let's hear from the experts, the people that are affected by the disease, and let's take them seriously. To you, the privileged elite, the fellow experts, let's think about TB and the way we respond as if it was affecting us and our loved ones. And let's try to see everyone else in the same way. If we actively attack all systems that punish people for being different, ending TB will be just one of the many positive results. I thank you.